Hi, my name is Dr. Matthew Reddick. I'm a genitourinary medical oncologist at UCLA School of Medicine, and I'll be moderating today's virtual tumor board. I'd like to introduce you to our panelists. First, we have our medical oncologist, Dr. Susan Slovin. Dr. Slovin, please tell us about yourself.
Thank you, Dr. Reddick. I work at Memorial Sloan Kettering Cancer Center in New York. I'm also a genitourinary medical oncologist whose focus has been on prostate cancer with a longstanding interest in prostate cancer immunotherapy and biologics. Thank you for having me.
Hello, I'm Dr. Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GU malignancies.
My name is Jason Abel. I'm a surgeon, the chief of urologic oncology at the University of Wisconsin.
I'm Dr. Tyler Fromm. I'm a radiologist at Washington University School of Medicine in St. Louis. I'm an assistant professor with appointments in both abdominal imaging and nuclear medicine. So I do a lot of oncologic imaging below the diaphragm.
So the first case is that of a 49-year-old female, a former smoker of 10-pack years, with clear cell renal cell carcinoma that was initially treated with a right nephrectomy and no adjuvant therapy for a clinical stage T1B N0 tumor, who now presents with oligometastatic disease to the 11th thoracic vertebra, to the body of that vertebra, and his status post corpectomy and adjuvant stereotactic body radiation therapy. So let's go into the case in some detail. So the patient presented with back pain. She had a very good performance status with minimal impairment with an ECOG performance status of 1. There's no significant medical history. Her social history, as noted, is notable for former smoking of 10-pack years, but no alcohol or drug use, and there's no family history of cancer. So in May of 2013, the patient undergoes a right laparoscopic nephrectomy, which reveals a 5.5 centimeter clear cell renal cell carcinoma, Furman grade 3, 0 of 1 lymph nodes were involved with cancer, and the final pathologic stage is T1B. At that point, observation with surveillance imaging was recommended. 6 years later, in April of 2019, the patient developed back pain and an MRI was performed. So Dr. Fromm, could we review the MRI?
Yeah, absolutely. So here we have selected sagittal and transaxial T2 weighted images of the thoracic spine, and we see at the T11 level that there is a marrow replacing lesion. That sort of higher signal intensity of the marrow has been replaced with a rounded lower signal intensity lesion. Exactly. There's no associated height loss at this point in time, so the vertebral body height is maintained relative to the adjacent vertebral bodies. Additionally, there's no extension into the epidural space, no evidence of spinal canal compression at this point in time. So those are the imaging findings on the provided images.
So thank you. So symptomatic solitary metastasis at T11. In April of 2019, the patient subsequently undergoes a partial corpectomy with spinal fusion. Dr. Abel, can you comment about that surgery and the approach that was taken for resection of this solitary metastasis?
In general, solitary bone metastasis we've seen in kidney cancer, complete removal is important, and the ability to completely remove that area. I know this patient got adjuvant radiotherapy, but we would try to completely remove the metastasis and to get negative margins, and that's very important when you're thinking about a metastasectomy.
Thank you. So the patient received postoperative stereotactic body radiation therapy, and I'll just ask Dr. Patel to comment on the role of postoperative radiation, as well as the role of radiation as the primary therapy to the metastasis versus surgical resection.
Yeah, I would start I would agree with Dr. Abel. If surgery is doable in any oligometastatic situation, that tends to be our preference as well. In the spine, when we give radiation, there are actually randomized data now that suggest that higher doses are more efficacious, particularly for pain control and local control in what we consider to be a relatively radio-resistant histology with a renal cell carcinoma. In this case, I think the approach that was taken is an excellent approach. A radical surgery as much as possible with full corpectomy with fusion followed by SBRT, I think is a great approach. There's just a couple technical issues that sometimes come into play with this. Now the radiation oncologist is faced with trying to visualize the spinal cord with spinal hardware in place, particularly with diffusion. So that can sometimes be tricky. Sometimes MRI will give you a good approximation of the thecal sac or the spinal cord. But if not, sometimes you do need to go with CT myelogram for radiation planning purposes. And we do try to deliver the radiation really as soon as possible, certainly working with neurosurgery to get clearance to deliver the treatment. But there are also some data to suggest giving the treatment soon after the surgery is beneficial. So in this case, I think really a great plan to optimize the control of this lesion.
Thank you. And can you comment on the role of the stereotactic body radiation therapy, the SBRT, versus conventional fractionation for the postoperative management of this lesion?
Yeah, there are data in the in spinal metastases without surgical management. There are data to support SBRT over conventional fractionation. So Dr. Sagal is the first author on a paper looking at 24 gray and 2 fractions versus the standard 20 gray and 5 fractions, which did show, again, better rates of local control and pain control. And pain control was the primary endpoint of that study. So I think here, sort of extrapolating from an experience without surgery, particularly, again, in a radio-resistant histology, to aim for the highest dose possible, using advanced techniques, even, again, in the postoperative setting. So there are data, again, without surgery, and I think we're sort of extrapolating here, and I agree with the approach.
So, and certainly it's beneficial in the sense that the patient will complete the radiation course much more rapidly, just in one day. So we'll go on with the case. A CAT scan of the chest, abdomen, and pelvis is done after the completion of the surgery and postoperative radiation. And all that's seen are postoperative changes at T11, but no metastatic disease that is noted. So now we're left with the question, what is the recommended next line of therapy? And I'll turn to Dr. Slovin, our medical oncologist, for comment.
Well, thank you very much, Dr. Reddick. I would say that the one thing that hits me as soon as I look at this case is actually the relatively indolent course of the patient's cancer history starting at 2013. And here we are at 2019 with final development of a metastatic lesion. The other thing that's quite interesting was a high-grade Furman's, and it was not exactly a small lesion, even though it was a T1B. So this talks a little bit about the biology of this particular cancer. Most of us would probably favor, I think all of us would probably favor just active surveillance at this time and the use of perhaps bisphosphonates just to keep the bone relatively strong. I know there are some clinical trials that are currently looking at adjuvant pembrolizumab, for example, versus placebo in patients who have prior M1 disease that's been surgically resected and is NED, and to determine whether or not there is any benefit to giving pembrolizumab in this situation. We would personally not do so, but these studies are ongoing. The one question I just wanted to ask, if I may interject, is the role of embolization prior to surgery. And I was just wondering in the sort of the retrospectoscope whether that's something that should have been done with the corpectomy or was not needed.
Yeah, so Dr. Abel, do you have any thoughts about the embolization and the potential for intraoperative bleeding and its impact by the embolization?
Yeah, I think this would, definitely be done by a spine surgeon. I think that there's very little role for embolization, but that's not my area of expertise, spine surgery. But I think it's something that probably would be technically very difficult, depending on the location and what the actual extent of the surgery is. It could be considered.
Right, thank you. And then as a medical oncologist, I too would agree with Dr. Slovin that given the indolent nature of this patient's disease with a 6-year disease-free interval before metastasis developed, monitoring the patient would be quite reasonable. And as Dr. Slovin mentioned, there is a phase 3 study that has and is evaluating the role of adjuvant pembrolizumab. Some initial data suggests that this approach can improve disease-free survival, even in patients with M1 disease that's been rendered NED without evidence of disease. But more to follow in the future when we get more follow-up from that study.
Dr. Reddick, can I make a couple other points? I think this is a very interesting case for a couple other reasons. So one thing is this patient developed their index tumor in their very early 40s. So this would actually be considered early onset RCC, and using consensus guidelines, this patient's really should have consultation with a genetic expert to evaluate for germline mutations in their DNA. So that's one thing that we should definitely have the patient discuss with, and then maybe even with their family afterwards. The other thing to highlight that I think is very interesting from this case is the need for long-term surveillance and a high index of suspicion. This patient started out with a stage 1 tumor, and they're beyond 5 years. So these patients really do need to be followed for a long time, especially the young patients. And when they do have pains, they need to be evaluated, because this would not be, a typical imaging and surveillance pickup.
Yeah. Thanks for those excellent comments. It is appropriate that the patient be referred for germline sequencing to identify a potential hereditary cancer syndrome. In summary, we have a patient who has oligometastatic recurrent renal cell carcinoma with a solitary metastasis to the T11, and the patient has undergone surgery and postoperative radiation. And given the protracted course of this disease, it was felt that close observation would be the best approach, with some consideration of adjuvant pembrolizumab. But in summary, the panel felt that observation would be the most appropriate course.